All right. Hello, everyone, and welcome. We'll go ahead and get started right about the top of the hour. So welcome, everybody. This is the inaugural session of our new Pediatric Ultrasound Multisite Conference. Today's topic is going to be on the acute painful scrotum. So the first thing I wanted to do before we dive in, I just wanted to give everybody a little bit of a introduction and just share a little bit about the format of how this conferences work. Just tell you a little bit about the background of kind of what we're trying to accomplish with this particular conference. So myself, Dr. Hai Tui Nguyen, and Dr. Judy Squires are kind of the three core members of this particular conference. This is modeled mostly after the prior iteration of this conference that existed with the Pediatric MSK SPR subcommittee. For those of you who may be familiar with that conference, that was run by Mahesh Thapa, Carl Marrow, and Kieran Frawley, and very thankful for their kind of mentorship as we got this particular conference set up. But really, this is going to be pretty informal for the most part. It's really just an outlet for us to kind of get together and just discuss some different ultrasound topics. Mostly the format of the lecture is going to be just a very short didactic component, kind of just introducing the topic for that month, just 5 or 10 minutes or so. But most of the cases, or most of the conference, will be centered around case discussion with the three of us, just kind of going through cases and discussing how we would approach them. If there's anything we could have changed as far as protocol or kind of just overall kind of approach to these cases. We also have some visiting lectures planned. We're also hoping to have some sonographers from our own institutions attend as well, and hopefully share their expertise as far as their scan techniques and protocols. These conferences will be held every month. Generally, we're going to be aiming to have these conferences on the first Thursday of the month by default. If there's a holiday or some other conflict, we may move it to the second Thursday of the month. But in general, you can plan on these being on the first Thursday from 1 to 2 p.m. Eastern Time. We have the next year or so of curriculum topics planned out at this point, really hoping to cover a very broad range of topics. Just to kind of give you some examples, we'll have a month on neonatal brain. We'll talk about vascular anomalies, contrast ultrasound, acute abdominal pain, and so on. But really hoping to hit on a very broad variety of topics. We have a YouTube page set up. There's nothing on it yet, but I will be uploading this particular conference to that after the completion of this conference. You'll be able to find all of our videos and recordings will be posted there and archived there permanently. So you can always watch them after the fact if you're not able to attend these lectures live. For those of you who may be SPR members, these videos will also be hosted on the SPR Express website, so you can also access them there. So with all that being said, let's go ahead and get into our topic. So kind of thinking about our approach to the acute painful scrotum. So, there's not really a whole lot of real estate that lives down in the scrotum as far as kind of anatomic structures we have to think about evaluating. But really kind of dividing these different things into, what can happen in the scrotum. We'll talk about each of these things today. So we'll talk about torsion, both testicular torsion as well as torsion of the either appendage testis or appendix epididymis. We'll also talk about epididymitis and orchitis. We'll talk about tumors, which certainly can present in the acute setting. We'll also talk about a few trauma cases as well. The last thing I think that I want to point out, and I really want to spend some time focusing on throughout our talk today, just really being aware of the different mimickers and how these diagnoses can all really overlap with each other quite a bit. So I think the acute scrotum is really kind of a deceptively difficult topic sometimes. When it's straightforward, it's very easy. But there really is a lot of overlap in each of these different diagnoses. I think there's a couple ways we can overcome that. Just thinking about our scan technique, we'll give you a couple different tips on just different things we can do and trying to differentiate some of these challenging cases. And then the other thing that we'll really focus on is the history of these cases. The history in these of these patients can really give us a lot of information. This particular example image I have on the right side of the screen here. Some of you may know Paula Woodward. She was one of my attendings when I was a resident at University of Utah. She was also one of the oral board examiners, and she always used to give us our kind of internal oral boards when I was a resident. She would show us a case very similar to this one. She would just put it up on the screen and ask us to start talking about it, wouldn't give us any kind of history or anything like that. What she really wanted us to ask was, what is the side of the patient's pain? Some people would kind of go down the rabbit hole and say, there's increased vascularity on the right side, go down the kind of saying this is a epididymitis or orchitis type case. Other people would say there's decreased flow on the left side, kind of saying maybe this is a partial torsion or something like that. But really just looking at this one single image, it's really impossible to know which side is the affected side. There's very clearly an asymmetry, but without knowing which side their pain is on, we can't really tell which side is abnormal. So again, we'll focus on that, just seeing how we can use these kind of historical components to figure out what's going on with these patients. This is just to share with you our scan protocol, just so that you all have it. Again, this will be kind of permanently available on our YouTube page. Everybody's available, or everybody has full access to this. If anybody's interested, I'm happy to send it out as well. I think this is relatively standard. As I said before, there's not a whole lot of structures to evaluate in the scrotum, but just kind of very, very systematic approach, looking at the right and left testicle, looking at the right and left epididymis, and looking at the inguinal canal as well. One thing I want to point out as far as part of our testicular evaluation, we started obtaining this transverse cine clip of the inguinal canal through the scrotum. I think this has really added a lot of value for us. If you don't have this as part of your protocol, I don't think it's necessarily intuitive to include that, but I would definitely recommend it if you haven't already. I think that's really helpful to evaluate the cord. We'll see a couple different cases where it really helped us make the diagnosis of either partial or kind of intermittent torsion. So that's one kind of, I think, more unique part of the protocol that I would point out. Then one question I wanted to go ahead and pose to Judy and Tui, the kind of idea of, like I said, we image always just by default. We look at the right side first, and then we look at the left. Now, I know some places image the side of pain first. I think the underlying concept is that if a patient has torsion, we want to identify that as quickly as possible. So some places I know will look at the side of pain first, and if a torsion is present, a sonographer would, pause the scan for a moment, go talk to the radiologist so they can kind of set things in motion to start, getting that patient to the OR, and then go back and finish the scan while that's happening. I'm curious if you guys have any thoughts on that, if either of you do that, if you image the side of pain first, or what your kind of thoughts are on that.
I don't think we have like a specific protocol, like you stated, where we image the site of pain first, but our first image is always that, image that you presented with the transverse, two testicles, if you can put them together with the blood flow. So with that, if there is absent flow, then they will immediately go straight to that and then call us. So I think they're aware enough what testicular torsion, like the absolute, finding is. And so I don't want to give too much of your talk away, but like whatever it is that's like needed to know for testicular torsion, they're acute to that. So then they will perform that, but otherwise they'll just continue on with the protocol.
I gotcha.
Yeah, our techs get the same transverse both testes comparison view. And if they're, one's in the inguinal canal and the other is not, they will try to do a side-by-side, keeping their settings similar. And our techs actually do the asymptomatic side first because it's a pretty quick scan. And so they, try to keep the patient as comfortable as they can for as long as they can. That's just what we do. And if there's really if there's like kind of diffuse pain or something, they always do the right first, usually.
Sure. Yeah, no, I think that makes sense. Like you said, it is such a quick scan. We theoretically might get the patient to the OR a couple minutes faster, but like you said, patient comfort, and also I think just kind of having things organized and systematic, and not having every study either start on the right or left side. I think it could get kind of confusing. So, like I said, I think there's maybe a couple minutes of time being saved, but yeah, like I said, we haven't done that yet. So. The next kind of protocol question, I know we chatted a little bit about this previously, but I'm kind of curious just to chat about this a little bit more as well. So this is a MFI image or microvascular imaging. I think that we don't include this as part of our standard protocol. I'm a little bit curious about if anybody has found some utility in this. Our text will include these images because I think they really do provide really nice, pretty images. You can see these really tiny vessels and, all the way out into the periphery of the testicle. Kind of just logically thinking about it, I would think this would have more utility clinically than I personally have found it to have. Especially in the, those younger patients where it can be really hard to see any normal flow, especially if the testicle's up in the inguinal canal or something. I would think it would be easier. I would think we would have found some clinical use for this, but at least I personally haven't, found a specific case where I've changed what I've said based on these microflow images. So I'm curious if either of you are kind of using this routinely, or if you have any kind of thoughts on this and how we can use it.
It's not definitely part of our protocol yet, although the power and color Doppler imaging is a little bit vague. So it's like, it says something like optimize your settings to best demonstrate flow. Usually it's not needed. They'll just do some power Doppler images. I have found that when they can't get flow, in cases of torsion, they'll demonstrate that there's legit no flow
Right.
using, it's called B-flow with our machines, but it's very similar appearance and technology. But I haven't changed what I've said based on a B-flow image or a microvascular imaging image just yet.
Sure.
Yeah, same. I think we have not been using it too frequently, actually, in any kind of imaging form, like anywhere, but it would be interesting to kind of just start looking at it. And like you alluded to, like in cases where the child's like much younger, or in the inguinal canal, or just like harder to find flow in general, just to see like what that would be like.
Yeah, and I think, Judy, I think you bring up a good point. Just definitively proving the absence of flow. I think this is helpful. I haven't had a case. I was expecting to find some cases where we don't see anything with color or power, but then we see subtle flow with this. But maybe that's a little bit beyond the sensitivity of this particular technique. But I think something to think about. Maybe we'll, as we get more comfort with this technique, we'll find more applications of it. But
yeah, one day I think we're going to have something we think is a mass and it's going to turn out to be an infarct, but we haven't had that case yet.
Yeah.
Showing absence of flow rather than flow in the lesion area.
Right.
One day.
And then I think a little bit more obscure, maybe I've seen some publications about using contrast ultrasound for testicular evaluation. Particularly, I think there's some papers about using it to kind of predict the degree of torsion. If we don't see any color flow, but maybe you see a few little bubbles percolating on contrast ultrasound, we can say at least there's some viability of the testicle, or kind of using it as a way of predicting viability. We haven't used this at all for testicular ultrasound. Have you guys used that contrast ultrasound at all for this application?
We haven't yet, mostly because I worry there'd be a delay to patient care.
Sure.
These kids don't always have an IV, and so that would take time. Obviously, if it's a case of testicular torsion, they're going to get an IV anyway, but usually they're on the way to the OR. So we have not yet used it. It's described in the literature. It sounds cool though.
Right.
Yeah, same here. I think a lot of our contrast ultrasound is reserved for outpatient settings. Just working up things that are routine. And so I don't know how that would play a role in just implementing it into the workflow. And then, would then you be on patient call for it. So I think it's cool, but then
Yeah.
I don't know if I really want to take call for contrast ultrasound
Right.
on top of everything else.
All right, cool. All right, next thing I just wanted to share, just so everybody has a copy of this, is the copy of our reporting template. Again, I think this is pretty standard, but just in case anybody needs a copy of this, happy to share this, just so you have something to work off if anybody doesn't have a template. But again, just kind of reporting on all those kind of standard structures that we include as part of our standard scan protocol.
Jeff, can I ask you a question?
Yeah.
Do you always have a chaperone in the room with you? I'm just seeing this in your template, and
Yes.
Wow. We've done it for female pelvis, but not necessarily for scrotal ultrasounds.
Yeah, so it's relatively new. So it's part of our hospital policy. They have a policy on, it's not specific for ultrasound, it's specific for, it kind of applies to all kind of sensitive examinations, including, any kind of physical exam that is considered to be invasive. So our particular hospital policy for any sensitive exam, if the patient is greater than 10 years old, by default, they have to have a chaperone, and the only exception is if it's an emergent exam and there's not a chaperone available, then we can get around it with that. But by default, every patient over 10 has to have a chaperone for either inguinal, scrotal, pelvic, breast, all those kind of sensitive exams. If the patient's less than 10, then we have to offer the chaperone, but it's at the discretion of the parent whether they want the chaperone or not. So we do have to include that just because of our hospital policy. This was changed about 6 months ago that we have to have chaperones now.
Is it an unrelated person, or can like the mom or whoever's with the patient count?
There's different definition that it says it has to be a clinical person, but the definition of clinical person is very broad. Oftentimes the sonographers will just chaperone for each other. So it can be a nurse, it can't be a parent. It has to be somebody who is a staff member of the hospital, but most often it's one of the sonographers and they just chaperone for each other.
Interesting.
So, yeah, it's a little bit of a challenge to, we're just so short staffed right now, like I think everybody is. So asking sonographers to kind of add that to their duties has been a challenge, but we've kind of figured it out at this point. So yeah.
Another question for you guys. Have you guys have any luck with importing numbers from the ultrasound machine directly into PowerScribe?
So that's one of my favorite things about where I work now. So, when I did my fellowship, that did not happen at all. We had to manually import all of these. So we have something called ModLink. So the machine has something called Scan Assist, which is kind of a protocol that's built into the machine. The sonographer will associate all of these different measurements, like this particular protocol or reporting template, for example, all of the testicular measurements and the volume. The sonographer will associate those with certain parts of the scan protocol. And then those get transferred to something called ModLink, which is then linked to our report. So all of these volume and dimension measurements, they automatically get transferred to our report. Same thing, we've been able to do that with almost all of our reports. So for example, like for renal Dopplers or liver Dopplers, all of the velocities automatically come over. So it's been really nice. It's a lot of work on the back end, kind of getting it all set up and getting it associated correctly. But I think it's really saved us a lot of time just having all that automatically populate our reports.
We have IT issues. We have not been successful in getting any of the software yet.
Yes, it's very helpful. I think it's definitely worthwhile to get it figured out, even then going through the painful parts on the front end. So all right, so let's get into a couple kind of different case discussions. So this is a 12-year-old presented with acute onset of right-sided pain. This is kind of a very bread and butter type case, just a classic case of epididymal orchitis. So our image on the top right here. So we have increased color flow within the epididymis itself and all the other kind of paratesticular soft tissues. The testicle itself also has increased flow within it. If we compare that to the left testicle, just to give you kind of a baseline comparison of what our normal technique showed the flow to be in the testicle in this particular case. Then I'll play through the cine clip here. So again, you can see all those kind of enlarged and heterogeneous appearing soft tissues and epididymis around the testicle with a little bit of a reactive hydrocele as well. So again, I'm just showing this as kind of a baseline. We're going to use this as a comparison for several other cases I'm going to show you today. I think in particular, epididymitis can be a pitfall in a lot of other diagnoses, a lot of other things that we'll look at, I think can look like this. So again, I'm just kind of showing this as a kind of baseline comparison to look at some of our other cases. So next case I'll show here. So this is that initial image that I showed at the beginning. So we can see that there is asymmetric flow between the right and left testicles. So there's, relatively more flow on the right than on the left. Again, we have to know which side is the affected side in order to determine which is the more concerning side. So this particular patient had left-sided pain, just intermittent over the course of 4 days. On our spectral Doppler, we can see that there is arterial waveforms on both sides. But looking at the, the color component of those images, definitely very clearly asymmetric flow with more flow on the right compared to the left. Looking at the epididymis, this is where I think we can kind of miss things a little bit. So looking at the left epididymis, this is very enlarged and kind of heterogeneous looking, increased flow on color. So, you could say this, is this an epididymitis case? I'll show you another cine clip here. So this is where I think that transverse cine clip looking at the cord really has a lot of value. So this image on the top left here, so we have a very classic kind of whirlpool sign to it. I'll play through the cine clip here. So again, you can see that very typical kind of whirlpool to this. So this was a case, we have a very clear twist in the cord. If I go back an image, I think that this is not epididymitis. This is more of what we would call this kind of so-called pseudomass. So this is a potential pitfall. I've seen a few cases where we have called this epididymitis when I think it was really kind of either kind of more of a kind of what we would call either a partial or intermittent torsion. So I think this is really where this kind of transverse clip through the cord really will add some value, making sure that we don't miss that twist in the cord. This particular patient, he was treated conservatively, which surprised me a little bit, but this kind of triggered a lot of conversations with our urologist, and I definitely learned a lot about this particular diagnosis of what they would call either kind of an intermittent or partial torsion. So to make the diagnosis of intermittent torsion, at least where I am, the urologists have asked us not to use that specific term in our reports. They feel that intermittent torsion is kind of more of a clinical diagnosis. To make that diagnosis, they prefer there to be, at least 2 or 3 episodes where the patient will have very, acute onset of pain that just spontaneously resolves, and have that happen at, at least a few times. So this particular patient, as I said, was treated conservatively. He had a follow-up with urology, had a repeat ultrasound a couple weeks later. Again, showing you that transverse clip, very kind of heterogeneous appearance of the epididymis still, but that twist in the cord is no longer present, has developed a little bit of a debris-containing hydrocele at this point. So in cases like this, we have started being more descriptive in our terminology. So we don't use the specific verbiage of calling this either partial torsion or intermittent torsion. We'll just be descriptive and say, there's a twist in the spermatic cord, but still with preserved testicular flow. Kind of let the urologist decide clinically how to approach these. So I'm curious to hear from either of you, Judy or Haitui, if you guys have any kind of thoughts on this, if you had this particular entity or, discussions with urology at your institutions, how do you guys approach this?
I'm kind of curious, do your urologists eventually go, so there's clearly a bell copper deformity, do they go do orchipexy eventually, or like what prompts them to take them to the OR eventually?
So I think it's mostly dependent on, I think like for this particular patient, if he had another episode like this, then and I'm going to show another case in a minute here of a kind of similar one where they acted much more promptly on this diagnosis. But I think if this patient had another similar event, then they would treat him in that case. But if they had just one single episode of, just an intermittent torsion that spontaneously resolves, then it seems to me that they are, treat those a little bit more conservatively until they have another episode. And then, that's what kind of prompts them to go intervene on it.
Yeah, that's interesting because here at CHLA, I haven't encountered that yet. So I have not had any direct feedback, but when I worked at Texas Children's, I know that there were cases where, we called intermittent and they did not like that either.
Right.
So I think they're at least at those 2 institutions, like, they just want us to be descriptive, describe the blood flow, and then truly only allude to it if we see, absent of blood flow initially, and then it returns. And then even then they're like, just describe that. Like we will read between the lines.
Right. Yeah. I think there's a lot of, at least from my understanding and talking with urology, there's really a lot of gray area in this kind of in between. So, if it's normal, it's normal. If it's a complete torsion, then that's, very straightforward. But everything in between, I think there's a lot more kind of clinical evaluation that kind of plays into how they treat those. So I think that's at least in those cases where they've asked us to just be more descriptive, let them kind of make the clinical decision on how to treat those patients. All right, let me show you another case that also found very interesting, kind of along the same diagnosis. So this was a 12-year-old. This patient actually came in as a outpatient for a hernia exam. So he had kind of had this off and on pain, had been going on for about a year or so. He had reported that, he had these episodes, that happened once or twice a month, where he would just have this acute onset of scrotal pain, would last for three to 4 hours, and then would just spontaneously resolve. So he had seen urology as an outpatient. They had some concern that he had a hernia. So he came into us as an outpatient for a hernia exam. So looking at this left inguinal longitudinal image, so it looks a little bit funny. So the cord looks kind of thickened. You could be maybe confused that there's a hernia here, but this is all kind of just thickened and boggy looking cord. As we look down towards the scrotal sac, there's this kind of enlarged and kind of heterogeneous looking soft tissue. So I think again that this is more of that kind of pseudomass appearance and that kind of congested epididymis and vas deferens. But I think this again could be confusing to just kind of call this an epididymitis and kind of funiculitis. But our sonographer again kind of astutely obtained that transverse image through the cord. So we can see as we get down into the inguinal canal and just right above the scrotum, can see that very discrete twist in the cord. So again, I said this was a outpatient. So we emergently sent this patient over to be evaluated in the ER. So he went over there and had a more formal testicular ultrasound done. So we can see there is asymmetric perfusion to the right and left testicles. This was one other question I had for you too, was how much weight do you place on the kind of waveforms of these testicles? So I think sometimes I get the sense that it's more artifactual, or they're just kind of getting waveforms from different locations. In this particular case, we have that twist in the cord, so I think this is real. So it looks like it's more of a kind of a tardus parvis waveform, lower velocities on the left compared to the right. But if you saw something like this without other concerning findings, would you raise concern about that, or how do you think about the waveforms as far as how you evaluate these?
I think for the waveforms, they are real and they truly are telling us the story. But I mean, to answer your question, like in isolation, I'm not sure, but like I would put it all in the picture and it does fit the picture. So I would say that it's real in the sense that I feel like you can get easier waveforms in the periphery and not centrally. And so that's the other thing I wanted to mention for your images that you're showing too. It's like, it seems like the sonographer was able to only get the better waveform more peripherally on the left. And then on top of that is tardus parvis. So that just means that there is truly decrease on that side.
Yeah, that's definitely a good observation about
that. Get that one centrally, yeah.
Right. Yeah, definitely a good point that it's easier oftentimes to get flow peripherally rather than centrally, especially in these kind of torsion cases. So yeah, definitely a good point.
Yeah, I agree. The clinical context is super key, and you can't interpret. Obviously, the Doppler is important. You have to pay attention to what the waveforms look like, but if it doesn't fit the history and what's going on with the kid, especially like infants where you have a hard time, the flow is so high resistance and they're moving. I interpret the Doppler with caution always. Right.
Yes, definitely a good point. All right. So then this is, again, that same patient. So this was about 45 minutes after that initial hernia exam. Again, showing you that transverse cine clip. By the time he got back to us to get this, so that twist in the cord was no longer present. So at some point in between when we scanned him the first time and this scan, he had kind of spontaneously detorsed. However, this patient, given that history, he had had a year of pain and had a very, I think, clinically consistent picture of intermittent torsion with these episodes that had been occurring a couple times a month with this, spontaneous onset of pain and then spontaneous resolution. So, urology felt very comfortable making the diagnosis of intermittent torsion. So they took him to the OR the same day. And he ended up having, by the time he got to the OR, they found a 360-degree twist in the cord. So at some time after this second ultrasound, he had kind of partially torsed. So again, this is kind of making that distinction between, clinically when they think there's an intermittent torsion versus when they kind of treat things more conservatively. This was the case where they felt very comfortable kind of clinically making that diagnosis. Just to share these are a couple, I think, very good papers about this topic, so either intermittent torsion, or this is kind of the verbiage that I think we tend to use more now, this testicular torsion with preserved flow. So these are both great papers if anybody wants to take a further look at these. But this particular one, I think, points out, the most pertinent findings. So the whirlpool sign, as we saw in that one case, we can't totally hang our hat on that. This case or paper talks about 80% of the time that whirlpool sign will be present. The other 20% of the time, meaning there won't be a whirlpool sign. So we have to kind of look at the more secondary findings, with those secondary findings being this boggy cord and this kind of so-called pseudomass formation that we saw a couple cases of. So those are kind of the main things to look for. So the whirlpool sign, the boggy cord, and then for that pseudomass. All right, so next case here. So this is a 11-year-old that came in with acute onset of right-sided pain. So again, this looks very similar to that initial case that we saw of that kind of very typical epididymitis orchitis. So it has increased flow within the epididymitis or epididymis, increased flow within the testicle itself. I'll play through the cine clip so we can see all this kind of enlargement and heterogeneity of the soft tissues around the core and the epididymis. Let's let this finish playing here. So the next couple kind of still images I'll show you here. So they're, our sonographer very kind of astutely identified that there's this very kind of echogenic avascular nodule, all this increased flow around it. So this is representative of a torsed appendage. So you can either have a torsed appendage of the epididymis or of the testicle itself. Clinically, it doesn't really matter all that much. They kind of have the same presentation and same kind of treatment and outcome. So I don't think we really need to perseverate too much on where the appendix is arising from. But I think this is just helpful to identify as a kind of potential cause of epididymitis. So if you see all those kind of inflamed and what looks like a case of epididymitis, just do a second scan through, see if you can identify this little avascular nodule. I think it just helps kind of be more confident about the diagnosis and kind of helps the patients and families and ED providers if we can kind of give them a very kind of clear etiology for where the epididymitis is coming from. So again, this is I think, helpful transverse cine clip through the cord. This again just gives us more confidence that this is truly just an epididymitis related to a torsed appendage. We can see this cord very nicely coming down with no twist within it. So again, just gives us more confidence that this is not a case of a kind of partial torsion. So this is one thing I was curious how you guys approach these appendages. So I think that this is an older paper, but I think it's commonly cited as looking at size criteria for making the diagnosis of a torsed appendage. This particular paper says that if the appendage measures more than 5.6 millimeters, then that has a very 100% specificity for the diagnosis of appendage torsion. I think that using size criteria makes sense in some ways, just because when you have those smaller appendages, it's really hard, I think, to see blood flow, even if they're totally normal. Do you use this size criteria, or how do you kind of think about, either making the diagnosis or of appendage torsion?
Had I known about the size criteria, I would have used it, but maybe that's too honest. I don't know. I agree. When they're normal and, they just happen to have like a hydrocele and it's like floating in the wind, the water, then it doesn't really scream inflammatory, and there's no like inflammatory changes. Then to me, like, that looks like a normal appendage. And then all the cases like you present, that's usually how I see them, as, just lots of inflammatory changes. And then you see something that is a little too large, that's avascular. And then I would definitely suggest that. Sometimes I do not even see a structure that's suggestive of like a torsed appendage. And then in that case, I guess I want to pose the question back to you both, is that, would you just still say, inflammatory changes in this age, most likely torsed appendage, but you're just not really like definitively seeing that ovoid hyperdense or hyperechoic avascular thing?
In those cases, I just say epididymitis usually. I am not ashamed to admit I did not know about this size cutoff either for testicular appendage torsion cutoff. But usually it's pretty obvious clinically. So you'll have a whole bunch of hyperemia and this like little avascular focus. Sometimes it's echogenic. Supposedly over time it becomes hypoechoic with like punctate internal foci, but I don't really care. I don't love measuring in general.
Yeah.
I feel like we measure structures on ultrasound that we don't measure at other modalities. So, but that's my bias.
Yeah. And that was kind of why I asked. Like, I've tried to use this in clinical practice a couple times, and I haven't found it to be super reliable. They don't have a huge number of patients in this particular study, and sometimes I see appendages that measure bigger than this and they, don't have any other findings of inflammation or anything like that. So I personally don't put a lot of stock in this, but, I'm glad that you guys don't seem to either. The other thing I was, to answer your question, hi Tui, I remember when I was in fellowship, I remember one of the urologists there telling me that what you're saying is true, that a lot of times when we see epididymitis in these kids, oftentimes it is due to a torsed appendage, even when we don't discretely see it. In those particular cases, I don't necessarily bring up the idea of there being a torsed appendage. I think I'm hoping that a lot of ED providers and urologists kind of know that that's a possibility. I've kind of tried to find literature about that to see, what percentage of the time that's true, what percentage of the time that there is an underlying torsed appendage in cases of epididymitis. I personally haven't been able to find anything, but I think just, recognizing that that is a possibility. And, if I see the nodule, I report it. If I don't, I just call it epididymitis and kind of leave it at that. So. All right, next case. So this is a 16-year-old that came in with acute onset of right-sided pain. So in our grayscale images on the top left here, so we can see that there's this kind of discrete area. It's very well defined, mostly echogenic, but some areas of decreased echogenicity centrally. In our color image, we can see there's some color flow along the periphery of it, but nothing internal. As I play through the cine clip here, again, we can just kind of see that no internal vascularity associated with this region. So this is a case of a segmental infarction. So the main kind of concern for this, this looks like a mass. Can we say that it's not a mass? I think this is a little bit of a challenge sometimes. They're not always this clear cut as far as having, complete absence of internal vascularity. So I think that in those cases, it's not necessarily a bad idea just to get a follow-up. Oftentimes these will resolve relatively quickly. This particular patient had a repeat ultrasound done just 2 weeks after this one. It had completely normalized. This area of abnormal echogenicity had completely resolved, and there's homogeneous perfusion throughout. So I think mostly just being familiar with this concept that segmental infarctions are possible. I think the other thing to keep in mind is that these segmental infarcts have a little bit different of a etiology than the more global torsions that we see. So these can be associated with other, either sickle cell or polycythemia, those types of things. Can be a vasculitis, or post-operative change can cause things like this. So I think that's one of the other kind of key distinctions between this and global torsion. Just kind of being aware of the history of the patient can also point you in that direction. If you knew this patient had sickle cell, then you might feel more comfortable just kind of coming down on this and saying it's a segmental infarction rather than invoking the possibility that this could potentially be a neoplasm. But again, I think just kind of being familiar with this diagnosis in general as a possibility, just recognizing that it can mimic a mass. But again, kind of I think maybe the biggest thing is that if we see that lack of internal vascularity, just because most tumors will be very hypervascular, which I'll show you at kind of a comparison case here in a moment. But do you guys have any other thoughts on this particular diagnosis?
There are reports in the literature about using contrast in this particular setting, looking at lack of vascularity of the segmental infarcts to be more confident excluding tumor.
Sure.
Yeah,
that makes a lot of sense.
Yeah, I don't have experience with that personally, but one day.
I'm guessing microvascular imaging was not performed on this because I don't see it.
Yeah, this was an older case before we had that capability, but yeah, it would be interesting to try that. All right, and then just to show you that comparison case I mentioned, so this is a tumor. So this ended up being a germ cell tumor. This patient did present to the ED with acute pain for about a week or so, but we can see the difference. This is just a very heterogeneous mass, but has very robust internal vascularity associated with it. So overall, kind of on grayscale, it's not too dissimilar from the last case, but again, just looking at that vascularity to say this is much more likely to be a tumor than something like a segmental infarction. All right, so my next couple cases are courtesy of Judy, so I'll discuss these with you too. So the first case is a 5-year-old that came in with acute scrotal pain. This first couple images just showed, a normal appearance of the testicular parenchyma. If we go to our next image here, so we can see that there's, very robust thickening and edema. within these scrotal soft tissues. As I play through the cine clip here, we can then see there's also very robust kind of hyperemia of those scrotal soft tissues. So this is a case of acute idiopathic scrotal edema. So again, this is just a diagnosis just to be familiar with, so you know what it is when you see it. So the main thing to keep in mind with this, so this is a completely kind of self-limited, will resolve in a few days. I think it's alarming to kind of parents and patients a lot of times, just because of the appearance of it. But it typically will just resolve in a few days. I think the main thing to keep in mind is, again, just overlap with other potential diagnoses, and the history again is very important for helping us differentiate those things. An infectious kind of cellulitis could, I think, also have this appearance. So knowing that this is just a painless and not any clinical concern for infection, I think that at least that's kind of how I think about differentiating that. Judy, do you have any other comments on this particular case?
No, yeah, this is one of those, the imaging findings are much more striking than the patient presents with. So, clinically, I think it can be also scary looking, like very red, but the patient doesn't have as much pain as you would expect with cellulitis. But again, the clinical history is key in this situation too, which we don't always have.
Right.
Hopefully eventually you get some history to
Right.
make those diagnoses.
Is there an etiology associated with it, or just kind of like a diagnosis of exclusion?
At least it seemed like some people thought there's maybe an allergic kind of angioedema type relationship, but I am not aware that there's like a very clear relationship.
Yeah, I think on labs there's eosinophilia, but not like the other, like leukocytosis, nothing like that. So I think the eosinophilia makes people think it's not. I don't think anybody actually knows, but
Yeah. And then another case kind of in the same vein of scrotal thickening, but just with a couple additional findings as well. So this is a 9-year-old came with scrotal pain and swelling. So, not as robust as in the last case, but there is some scrotal thickening and hyperemia. But we can also see that there's some intrascrotal involvement. So that, the testicle itself looks okay, but all of this kind of soft tissue thickening and hyperemia of the epididymis. The next case here is, so again, just showing you all of that kind of heterogeneity and enlargement of the epididymis and kind of other intrascrotal soft tissues with a relatively normal appearance of the testicle itself. So this is the case of HSP, or Henoch-Schonlein Purpura. So again, this is just to be, I think, important to be familiar with the idea that you can have scrotal involvement with HSP. Again, this is, I think, where the history really helps us a lot, being familiar if the patient has the other findings of HSP. So either, rash or arthralgias, abdominal pain, those types of things. I think in isolation, if all we had was these imaging appearance that I'm showing you here, and we did not have any of that additional history, I think it'd probably be a more difficult diagnosis to make for sure. But just to kind of be aware that HSP can have scrotal involvement. So typically we'll have, scrotal thickening, epididymal thickening, and then can have little hydrocele like is present in this case.
Yeah, supposedly, if you believe the literature, like as much involvement of the tail as the head can lead you towards a diagnosis of HSP. Obviously, if it's bilateral, but sometimes that's not helpful.
Sure.
I feel like sometimes infectious epididymitis it involves the tail as much as the head.
Right. Right. And then again, changing gears again, talking a little bit about trauma. So this is a 15-year-old came in with testicular trauma. So I think this is a couple of cases I'll show you here to mainly make the distinction in our kind of terminology and how we think about these cases. So this particular case, we can see the margins of the testicle along the superior pole are relatively well preserved. But as we get to the inferior pole, we just have this big mess down here with all this kind of heterogeneous tissue. On color flow, we can see there's, preserved or probably increased flow to the kind of more normal appearing testicular parenchyma, but no flow to this kind of inferior component of it. So this inferior component probably represents kind of, combination of blood products and kind of this extruded testicular parenchyma. So the main thing I kind of think about these is trying to identify whether the tunica is intact or not. So the tunica is kind of this fibrous sheath that kind of envelops the testicle. So we can see, some components of it up here along the superior pole that look intact, but as we get down to the lower pole, just becomes obliterated. We don't see that sheath at all anymore. So when we see disruption of the tunica, then in those cases, we can call it a testicular rupture. In those cases, I believe are the ones that, more typically would go to the OR for repair. So again, the main thing to kind of differentiate is whether the tunica is intact, and I'll show you kind of a comparison case in a moment here. This is a cine clip to that same patient, again, just giving you another look at it, as we kind of have all these areas of probably kind of conglomerating blood products, but again, all of that extruded testicular parenchyma and testicular rupture. For comparison case, this is a more what I would think we would call a testicular fracture. So again, patient with testicular trauma has this hypoechoic band that kind of traverses through the lower pole of the testicle. On our color flow images, we can see that there is some preserved flow to that testicle that's beneath what I think is that fracture. So in the, we can see the tunica, I think, looks intact. The overall kind of ovoid shape of the testicle is still intact. So this would be something that they would generally just manage conservatively. So there's this testicular fracture where there's kind of this disruption of the testicular parenchyma itself. But as long as the tunica is intact, then those would be typically would be treated more conservatively. And I think this is, again, just kind of thinking about the terminology and verbiage. Even when I was looking up cases to present for this conference, I found there was kind of a good bit of heterogeneity in, at least in my group, how we kind of report these, specifically the verbiage of either fracture versus rupture. So at least that's kind of how I think about it. If the tunica is intact, then I would call it more of either fracture or intertesticular hematoma, versus if the tunica is disrupted, then would call it a rupture of the testicle. Do you guys have any other thoughts on how you think about that?
No, I think I agree with that terminology. I mean, when I was training and just kind of reporting, it was more important to just kind of describe like whether the tunica is intact or not. And so I feel like in a way, that's kind of like the determining factor.
I agree. I think your terminology is right. Yeah.
All right. Yeah, and I think like in a case like this, for example, saying whether there's a fracture, intertesticular hematoma, I think that some of that is, I think, hard to say exactly what's going on sometimes, but I think just thinking about it in the broader terms of whether the tunica is intact or not, I think that's what matters most clinically. So I think that's what we should pay the most attention to.